The other big trial that we use is EMBRACA, which again, a very similar trial, took patients who had 0 or more than 1 chemo regimens, could have been triple negative or hormone receptor positive. And in this case, they actually had patients who had metastatic disease in the brain. And this was, they were randomized to physician choice of chemo, CAPE, eribulin, gemcitabine, or vinorelbine versus talazoparib. And in this trial, there was progression-free survival benefit. Again, a hazard ratio very similar to that of the Olympiad trial with olaparib. So these drugs are likely similar. And there appeared to be at least the glimmers of a survival benefit. But again, this is interim analysis, so we need to see further data to see whether there would be a benefit to talazoparib. It would be very interesting, hopefully, when they do this additional survival analysis, Jennifer Liddon et al. On this trial, that they cut the data the same way that olaparib was cut in the patients that had not had prior chemotherapy. This is going to be a really, really interesting and potentially changing, something that changes our practice. Because I think a lot of us up front said, listen, there's no survival benefit, we don't really care, but if the patient it really does have a survival benefit in the absence of getting chemo, then I would really argue to give these agents before chemotherapy. And again, the safeties are very similar to the big one in this. I think the unique one being anemia as well as neutropenia, but it really wasn't bad. The incidence of neutropenia was actually less than chemotherapy, about 3.1%. That was grade 4.
So that was great. I mean, really, that was an excellent review of what we've seen in the data with PARP inhibitors. And I think so encouraging that we finally were able to get 2 drugs approved for patients with germline BRCA mutations and metastatic breast cancer, both ER positive and ER negative, but all HER2 negative. Now I think the big question is how we incorporate the PARP inhibitors into the patient. As you recall, this is a patient who has metastatic disease with lung involvement, but not a lot of symptoms and bone, and has a tumor which is triple negative, but also PD-L1 testing is 0. So what treatment options would you consider for this patient, and how would you make a decision? Adam, do you want to start with that?
Yeah, I mean, I think that, the patient doesn't have that many symptoms, and if really that data, does hold up from the analysis, I think she really should get a PARP first. I think that if there was a true survival benefit if people get PARP up front, I think that's where I would go. And that's what I would say.
And how do you decide?
Well, so I think in this case, when the patient is PD-L1 negative, it's pretty straightforward. You have randomized trials showing superior, at least PFS, versus chemotherapy, and they're at least as well tolerated as chemotherapy for most patients. So you can you avoid the infusion. So I think for this patient, PARP inhibitor is a very good choice. I think it gets more complicated for the PD-L1 positive patients with a BRCA mutation.
Yeah, I think that is a really good point. I think we don't know what to do, although there's a lot of interest in PARP inhibitors as maintenance, and studies that will be looking at the overall triple negative breast cancer population with immunotherapy and PARP inhibitors as combined treatment as maintenance after a chemotherapy IO induction, or even just a chemotherapy induction. So that will be interesting because we'll be able to look at the BRCA mutant population in a subset analysis.